If you have inadvertently disclosed the identity in the paper, identity of yourself or your institution, that paper will be disqualified from awards. Identity in the sense from the place from where you come, who is your guide, what is the institutional affiliations, the identity that affects that may bias me. That is the case. Identity person is in front, that doesn't matter. So with these two things, I call upon the first speaker, first paper, Dr. Aparajitha.
A very good morning to one and all present here. I would like to be presenting a case on an adult recurrent laryngeal papilloma who underwent tracheostomy, multiple microlaryngeal surgery with excision, laryngeal web separation with a keel, and removal. So it's an interesting case report. So we came across a 63-year-old female who presented to our OPD with complaints of change in voice since 10 years, noisy breathing since 1 year, and difficulty breathing since 3 months. We've been following her up for many years. So change in voice was insidious in onset, which was there since 10 years. It was gradually progressive. Hoarse in nature, difficulty in raising the pitch of the voice. No diurnal variation was noted. Noisy breathing, which was noticed since 1 year. Insidious in onset. Since this was one of our visits in our multiple visits, she is a known case of diagnosed recurrent laryngeal papillomatosis and has undergone multiple microlaryngeal surgeries. And her childhood was uneventful, and there was no contributory family history. Personal history, she's a tobacco chewing patient for the past 30 years. So on general physical examination, she's an elderly female, poorly built and nourished. Patient was conscious, cooperative, oriented to time, place, and person. Her vitals were stable. On systemic examination or coming to ear, nose, throat examination, one of the positive findings included an examination with a 70-degree rigid Hopkins endoscope showed multiple papillomatous lesions over the laryngeal surface of the epiglottis, bilateral true vocal cords, anterior commissure abutting the subglottic mucosa, and laryngeal web was noted. So this was one of her follow-up visits where we noticed a laryngeal web. So this is the image. So her previous histopathological image showed squamous papilloma. She was a diagnosed case, so on one of her visits she showed laryngeal web. So our diagnosis was adult onset respiratory recurrent papillomatosis with laryngeal web. Our line of management included tracheostomy for the stridor with which she had presented initially, and in the subsequent setting we did multiple microlaryngeal surgeries and excision. And then, once we found the web, we did a web excision followed by laryngeal keel placement. This is an image of showing the placement of the laryngeal keel. So laryngeal web separation and laryngeal keel placement was done, and we put the patient on regular follow-up. So she follows up once in every 1 or 2 months. So coming to discussion, as we all know, recurrent laryngeal papillomatosis is a rare chronic disease caused by the human papilloma virus. It has 2 types, juvenile onset and adult onset recurrent papillomatosis, where adult onset is noticed after the age of 14 or after 20 and between her 20 to 40 years, and recurrence is usually less when compared to juvenile onset recurrent papillomatosis. So it is a very frustrating condition, although being benign, because multiple surgery patient, and it is a very frustrating symptoms. So these are the statistics. The incidence is around 4.3 per 1 lakh in children and 1.8 in 1 lakh in adults. So usually the reservoir is said to be the anogenital tract, and it is from here that the infection is acquired. Whereas adult onset, it can be transmitted sexually or maybe a reactivation of HPV infection acquired during birth instead of a de novo exposure during adulthood. So take-home message included, although is compared to JORP, considering the likelihood of recurrence is of importance so that we can plan the management accordingly, and it will be effective in the long run. Thank you.
Any questions from audience? No.
Sir, it was kept for around 1 month, sir. 1 month. Yes, sir. And then we had to plan her for keel removals. Sir, we usually use mitomycin C and topical application of mitomycin C is usually used, sir. Sir, exactly to prevent papillomatosis, we couldn't use any medical line of management. So we put her on follow-up, sir. She follows us up once in every 2 weeks to 3 weeks, sir.
So, ma'am, this is special needle which is used for it. Can you name the needle?
Needle which is used for, sir?
For putting this stitch for a key, there is a special needle which is available in the market. So, for doing the endoscopy.
I'm not aware of it, sir.
My side one question. What instruments did you use? You didn't mention that in your paper.
Sir, external approach of keel placement and endoscopic monitoring was done, sir. Correct. Sir, we actually used the regular incision. We didn't use lasers, sir. So we didn't use lasers, sir. So we did microlaryngeal examination and removal using normal.
Was it a choice?
Sir, it was a necessity, sir, because we couldn't.
Thank you.
Sir. Thank you, sir.
Good morning, everyone. I am Dr. Maneesha. I am going to present a study on the anatomical variations of recurrent laryngeal nerve in relation to inferior thyroid artery in patients undergoing thyroid surgeries. Recurrent laryngeal nerve is a branch of vagus nerve, first described by Galen. It carries sensory and motor fibers to the laryngeal structures. Course of RLN is according to the development of arteries related to it. On right side, it loops around the subclavian artery, and on the left, it loops around the aortic arch. During ascending into the neck, the RLN will cross the inferior thyroid artery. The main anatomical variations classified in the literature are recurrent laryngeal nerve anterior to inferior thyroid artery, RLN posterior to inferior thyroid artery, and in between the branches of inferior thyroid artery. The variations of recurrent laryngeal nerve are prone to iatrogenic injuries. The incidence of RLN injury worldwide is 0.5 to 20%. Thorough knowledge about the anatomical variations is essential to prevent injury to the nerve. So my aim of my study is to identify the anatomical variations of recurrent laryngeal nerve in relation to inferior thyroid artery in patients undergoing thyroid surgeries, and to contribute to the existing body of knowledge on the relationship between the recurrent laryngeal nerve and inferior thyroid artery for better surgical outcomes. It's an observational study conducted in the Department of ENT at a tertiary care center. Duration of my study was 18 months, and it includes all patients undergoing thyroid surgeries. All patients undergoing thyroid surgeries were included, and patients who had advanced stage of thyroid carcinoma, history of previous radiotherapy, history of previous thyroid surgery or neck surgery, and patients with vocal cord palsy were excluded from my study. So first, detailed history was taken. Basic investigations, thyroid function test, indirect laryngoscopy, video laryngoscopy, ultrasonography, FNSC were done, and CT scan was done as and when required. The patient who met the inclusion criteria were subjected to medical and general anesthetic fitness. Depending on the diagnosis, appropriate surgery was done. Come to the results. So we have done 38 thyroidectomies, in which most of the patients were female, 89% were female, and 11% were male. And the peak age group was 13 to 40 years of age. And the most common diagnosis was colloid goiter, followed by follicular neoplasm, and then by lymphocytic thyroid nodule. So we have done 38 surgeries, and in that 50% was right hemithyroidectomy, and 32% total thyroidectomy, and remaining left hemithyroidectomy. So relation of recurrent laryngeal nerve with inferior thyroid artery on the right side. So we have identified 31 recurrent laryngeal nerves in the right side, in which 29 was posterior to the inferior thyroid artery, and 2 were anterior to the inferior thyroid artery. So on the left side, total we have identified 17 nerves, in which 16 were posterior to the inferior thyroid artery and 1 was anterior to the inferior thyroid artery. So come to the discussion. Total of 48 recurrent laryngeal nerves were identified with 31. that is 64.6% on the right side, which showed 2 RLN anterior to artery and 29 posterior to artery. On left side, 70 nerves identified. One RLN was anterior to artery and 16 posterior to artery. In a study done by Nisha S.R. Manuel et al., RLN was predominantly posterior to the inferior thyroid artery on both sides. That is on the right side 78.33% and on the left side 100%, and in 21.66% anterior to inferior thyroid artery on the right side. Come to conclusion, the recurrent laryngeal nerve shows some anatomical variations that can potentially compromise the safety of thyroid surgery. So injury to the RLN can cause RLN paralysis with the symptoms ranging from almost undetectable hoarseness in unilateral lesions to stridor and acute airway obstruction in bilateral damage. In the present study, RLN was posterior to inferior thyroid artery, most commonly on both sides. So fully understanding the anatomical variations of the RLN may help surgeons dissect the RLN in a safe, fast and correct way. Therefore, it is vital to determine the anatomical position of the RLN in thyroid surgeries. These are my references. Thank you.
Any other variation you know?
No recurrent laryngeal nerve, sir.
Yes. Non-recurrent.
No recurrent laryngeal nerve, sir.
What is the recurrent triangle?
Recurrent,
To identify the recurrent triangle?
so the Lord's triangle here, sir, and it is medially bounded by the trachea, esophagus, laterally by the common carotid artery, and superiorly by the inferior border of thyroid gland.
Out of this study, whether there are any patients with any recurrent laryngeal nerve palsy?
No, sir.
No,
No,
were-
sir. All was okay, sir.
all 38 were good?
Yes, sir.
Okay, it's good.
So you have presented this topic. According to you, which is favorable position and which is unfavorable position?
Sir, sorry, sir.
Which is the favorable position of the artery and which is unfavorable position of artery for surgeon? You are talking about relation of ITA
Relation, sir.
with
I didn't-
recurrent laryngeal nerve.
Haan, sir.
You have presented two scenarios. Either it may be anterior or it may be posterior.
Yes, sir.
During surgery, what did you find? What is the better to have?
Haan, sir. Sir,
Whether it is anterior or posterior? You didn't get question. Am I clear?
Yes, sir. And I think if there is more branches, so it will be.
You are not talked about
No.
branches.
Yes, sir. So in my study, yes, sir. So in my study, I think if it is anterior to the.
It is favorable.
Yes.
Logic. It is logic. And one more point, one more thing that I wanted to point out.
Yes.
You have not mentioned about the relation where the ITA goes through the branches of thyroid or branch of recurrent goes through the branch of two branches of ITA. These are variations and that should have been noted.
Yes, sir.
So what do you think was the reason that you have not noted it? You have described anatomical variations in only two ways.
Yes, sir.
Either it is anterior or it is posterior.
Yes, sir.
You have never mentioned branching or neither of ITA nor of recurrent.
Yes, sir.
I want to know why you didn't encounter that, because that is 100% you will be seeing something like that in 38 thyroids. But your surgeries didn't identify that. What was the reason? What could have been reason?
Out of this, all 38 patients, anything different you found out? Or only you were anterior and the posterior? This was the
Yes, sir. I have found multiple branches to the RLN. We have found multiple RLN branches.
So what was the relation of each branch to the ITA?
that was his question. That was the question.
Each branch.
And why it can happen is you are targeting ITH way too late, not near the thyroid. That may be one of the reasons.
Thank you, sir.
Good morning, everyone. Today I'm going to deal with unraveling laryngotracheal stenosis, the recent techniques in management. I'm Dr. Shanmugadevi, and the laryngotracheal stenosis is a complex problem, and the management is difficult. As we all know, it requires a long-term follow-up. And we all know the most common cause is the prolonged intubation, and there is a lack of standardized strategies for the management of laryngotracheal stenosis. And as we all know, the grading which we use commonly is Quatermain grading and McCaffrey, which includes glottis, subglottis, and trachea. Today I will be dealing with a series of 5 cases which we have dealt in our center and managed subsequently, and I would like to highlight on coblation which we used in all these cases. First case is a 68-year-old male who presented with respiratory distress post-extubation. He was found to have a grade 2 tracheal stenosis at C6 to C7 level, and he was managed in private hospital with multiple application of mitomycin C, which was failed. And in 2014, patient was developed stridor, and he had grade 3 stenosis, and in CT scan he was found to have a craniocaudal extent of 2.7 centimeter, and this is the stenosis which is seen, which is a grade 3 stenosis. So he underwent a laser-assisted tracheoplasty with T-tube insertion, and subsequently he was planned for decannulation 2014, but he had multiple failed trials of decannulation from 14 to 18. In 21, patient reported to our center with regurgitation of food from the T-tube, from the stoma. So we were suspecting a TE fistula, and we did all the evaluation for TE fistula. However, there was no TE fistula found, and it was found the T-tube was pressing on the trachea, and which was causing the regurgitation. So we managed the patient with granulation tissue excision followed by tracheostomy tube insertion, and patient was discharged thereafter. In April 22, again patient on examination was found to have a Quatermain grade 2 stenosis, and there was a 2 centimeter long stenotic segment at C7 to T1 level. Now this time we did an open approach where we used a coblation. We used an endotracheal tube, which is a flexometallic tube. We have pulled the tube downwards so that we can enter the trachea from down through the stoma, and we removed the granulation tissue with the use of coblation, and also we applied mitomycin C locally. And thereafter we placed the patient on T-tube, and he was started on a short course of steroids, and he was discharged. This was the post-op video of the patient and post-decannulation, and this is the present video of the patient. Coming to case 2, he was a 65-year-old male. He was evaluated by cardiologist for breathlessness. On FOB, he was found to have a subglottic growth, and he was referred to a center, and he was having subglottic stenotic growth. And CT scan, there was a 2 centimeter long stenotic segment, and we did a rigid bronchoscopy with balloon dilatation initially, and patient again presented with a subglottic growth of grade 2. Now this time we did an coblation assisted removal of the granulation tissue, and we sent the tissue for HPE, which came out to be GPA. So hence we referred the patient to a rheumatologist, and patient was started on steroids, and subsequently patient came to us a grade 3 stenosis. So this time we did an open approach where we use a Sheehan-Yanley technique with insertion of T-tube, which is an anterior cricoid splint followed by lateralization of the trachea. No post-op patient was started on oral steroid for 8 weeks on a tapering dose and placed on T-tube and underwent decannulation. This is the present video of the patient. Coming to case 3, it is a 3-month-old child with post-extubation failure, and he was found to have subglottic stenosis grade 3. And February 24, he presented to us, and he was having a subglottic stenosis, and FOL he was having grade 2 stenosis. We did in balloon dilatation and application of mitomycin C initially. This is the picture showing balloon dilatation and mitomycin C. And next he went, again patient had a grade 1 stenosis, and again patient was subsequently taken up for coblation assisted removal of fibrotic bell followed by balloon dilatation. Presently patient is planned for decannulation in December. This is the initial presentation. We did a coblation and balloon dilatation. This is the case 4. Here we can see he was a 27-year-old male with post-RTA intubation. He had a stenosis, and he was having grade 3 stenosis. This is the video of showing grade 3 stenosis. This is the laser initially we did, laser assisted removal of granulation tissue, and subsequently patient was again presented with 30% of narrowing. This time we did for an open anterior laryngofissure with coblation assisted removal of the granulation tissue, and this is the T-tube which was seen post-op in the subglottic region. Again, patient had on follow-up, patient had grade 1 stenosis. Subsequently, patient was planned for decannulation and the secondary closure of stoma was done. Coming to case 5, he was a 22-year-old male with post-history of poison. He developed breathing difficulty and exertion. On FOL, he was found to have grade 2 stenosis, and on CT scan, he was having narrowing of the trachea at C7 to T1. This is the coblation assisted removal, which we used an open approach to remove the coblation band, and this is the insertion of T-tube, which we can see through the open oral cavity. So this is the management. Coming to management, I just want to highlight on the grade, based on the grades of stenosis, there can be initially for grade 1 we can do an endoscopic approach, grade 2 and grade 3 we can go for coblation as we did it in our center. We can go for an open approach where we can use an a fluxometallic endotracheal tube with the coblation, because coblation has got rapid, there will not be requirement of repeated ablation, which we use commonly with laser. So that is how the management differs in our center. So prevention for laryngotracheal stenosis, we can do, as we all know, we can deflate the cuff every 2 hourly if the patient is on prolonged tracheostomy tube. Regular suction toileting and sterility of saline can be used. I will just highlight on the Shanmugadevi technique, which we had used in center, which involves opening of the trachea anteriorly with the splint and lateralization of tracheal wall. Thank you. No sir, I had mentioned it was first 2 cases were tracheal stenosis, third one was a subglottic stenosis, fourth one again was an tracheal stenosis, sir.
Do you feel that we should talk about laryngotracheal stenosis or laryngeal stenosis separately and tracheal stenosis?
Yes sir. Yes sir. Laryngeal stenosis can be supraglottis, subglottis or glottis. However, tracheal stenosis, which we have dealt.
Should we use the term laryngotracheal stenosis or should we group these patients as such together to understand the effect of your modality of treatment?
So we should ideally should be laryngo. I had used laryngotracheal because it was a subglottis also, many of the cases. So that's why.
Whenever we want to study the results,
So.
we have to study the results separately for subglottic and separately for
So.
tracheal. And what is the best option for tracheal stenosis?
Tracheal stenosis, sir, based on the stage grading of stenosis, it can be, we can use a laser or endoscopic approach where we can apply mitomycin C or local infiltration of methylprednisolone can be done, sir. So that will be helpful for the patient. And also in our center we give a short course of steroid also, which will.
What is the commonest site for developing tracheal stenosis after this intubation, long-term intubation?
Prolonged intubation, the trachea, if a patient is having injury over the trachea, T2 and T1 and T2, as we have commonly come across, most of the patients had a level at T2 to T4 tracheal ring. Because in tracheostomy, we do tracheostomy at that site T2 to T4. Otherwise, for intubation, sir, the lower end of the endotracheal tube, which lies at that level, sir.
What is the culprit? Is it lower end or is it cuff?
The cuff also, sir, if it is not inflated, deflated frequently, it can cause pressure and subsequently the submucosal edema can cause the stenosis. So.
Good morning. Today's the topic for the paper presentation is a study to describe the findings of laryngeal inflammation and narrowband imaging laryngoscopy with the corresponding reflux symptom index score in cases of the laryngopharyngeal reflux disease. So coming to the introduction, we have the 3 terms. Entity is gastroesophageal reflux, GERD and LPR. GER is the reflux of the backflow of the contents of the stomach into the esophagus without any symptoms. If it is associated with symptoms, then it is known as gastroesophageal reflux disease. And when the reflux of gastric esophageal occurs in the larynx and it involves the mucosa of the larynx, then it is known as laryngopharyngeal reflux. So what is known? The Belaf Sky and Coleman 2000 in 2002 he has given this index, reflux symptoms index and reflux findings score. He has given in reflux symptoms index. He has given self-administered 9 question assessment, which has a good reliability, reproducibility, and validity. The RSI score of more than 10 is likelihood of LPR, whereas the RFS score of severity score of 0 to 26. If reflux finding score is greater than 7, then highly suspicious of LPR. So the aim is to describe the laryngeal inflammation in cases of the laryngopharyngeal reflux disease using narrowband imaging with corresponding reflux symptoms index score. Then the primary objective was to assess the mucosal inflammation of the larynx by using NBI light, narrowband imaging light in laryngopharyngeal reflux disease patient. The secondary objective was to describe the NBI light laryngoscopy findings. The place of study was Department of ENT in Tertiary Care Hospital in Western Maharashtra. The study design was prospective study. The period of study was 18 months. The study populations were the newly diagnosed cases of laryngopharyngeal reflux disease based on the RSI score greater than 10. So the inclusion criteria, newly diagnosed cases of the laryngopharyngeal reflux disease, where the RSI score was greater than 10, age greater than 18 years. The exclusion criteria, patients on any anti-reflux treatment and allergic disease such as allergic rhinitis and allergic bronchitis, professional voice users, materials and methods. The patients were selected, the informed written consent were taken, then the patient were given questionnaire of reflux symptoms index, then RSI score was calculated, then if we found that RSI score was greater than, then we were taking patient into our study. So the video laryngoscopy was done, then narrowband imaging was done subsequently. Then the ImageG software was used for the calculation of the red, green, blue values, then interpretation of the data and conclusion was done. So in our study, we had 80 patients. The age of the group of participants were 23 to 65 years. The mean age was 39.48, female being 34 and male being 46. So the results of the reflux symptoms index, most of the patient, these are the common presenting symptoms in our study. So most common presenting symptoms was hoarseness, which was 41, followed by chronic cough, then subsequently global sensation in the throat, followed by dysphagia and throat clearing and heartburn. This was the mean, median, standard deviation interquartile range, which was calculated for the most common symptoms that we found in our patient. The RSI score mean value was 22.50, median was 22, standard deviation was 3.65, and interquartile range was 21 and 23. Among the patient, majority had moderate reflux symptoms index, 70%, while 23.8 had mild RSI, and 6.3 of the patients were found to have severe RSI. This was the reflux finding score after Hopkins laryngoscopy, and we found the reflux finding score mean, median, mode, standard deviation as shown in the slide. The mean, median, standard deviation interquartile range for the age, reflux symptoms index, and reflux finding score are shown in this chart. Then we calculate the RGB values of white light also. The RGB values were calculated and mean was found. Median and standard deviation was found. Then the results for NBI, narrowband imaging, the R value was 34, G value was 27, B value was 28, and RGB values mean was 30. So G value mean was 27.80, which was statistically significant. There was significant correlation between G value and RGB values of narrowband imaging and the reflux symptom index. The P value was 0.05, which was statistically significant. So these are the scatter diagram which are shown here. The simple scatter diagram of R value, G value, and B value. We can see in the x-axis and y-axis we have G value, and the x-axis we have the reflux symptoms index. We can see the points. These are the data. This is scatter, and these are the concentrated horizontally in the value between 20 to 25 being significant G value. There was also the significant positive correlation between reflux finding score and reflux symptom index. The p-value was 0.014, which was statistically significant. We can see the data was data clusters seen in between the two square, and this was found to be significant. So there was significant positive correlation between reflux finding score and reflux symptom index. There was also significant positive correlation between G value, RGV value of narrowband imaging and the reflux symptom index. There was no association between reflux symptom index and age of the patient. There was no association between reflux symptom index and severity of the symptoms. So in conclusion, by integrating the RGV values analysis into our routine clinical practice, healthcare professional, we can achieve a more precise and objective assessment of the laryngeal inflammation. And also we can, this method not only complements the traditional diagnostic techniques, but also enhances the ability to monitor the treatment outcomes effectively. We know that laryngeal LPR can lead to the other disastrous things in the larynx, which can predispose even to the laryngeal cancer in the later form. Then the NBI value has potential to become a promising tool for making individualized clinical decisions in the field of the laryngology. These are my references. Thank you. Sir, we use ImageJ software for calculating the RGV values and sir, we used NBI, narrowband imaging.
I was asking which system? Which camera, what you have used? Which camera you use? That matters a lot for the RGB.
Okay.
What you are talking about. Whether it's a Olympus system,
He's talking about hardware.
Okay.
It matters.
what you have used, whether you have used a nasopharyngeal laryngoscope, whether you have used a 70-degree laryngoscope, or what was the system, whether the xenon light was there, whether it was a LED was there, because this matters a lot for the answer. वो बता रहा है. So you got the
yes sir.
So what is the system in your department?
Sir,
have you seen anyone narrowband imaging?
Yes sir, we.
So what was the system?
Sir, in narrowband imaging, sir, we use that laryngoscope.
Which one?
Name, I have given specific name. But that depends, no, sir.
Yes.
That's the main.
For all PGs, what I want to tell you, the first day that you go into, check the configuration of your instrument. Which camera you are working?
Yes, that's what.
Sir.
What are the specifications of that? We should know. Without that, we cannot go ahead.
Yes, sir.
There are a lot of different
Because your study is good. If you
Yes sir.
Yeah. Second question, I
Yes, sir.
want to ask you, as this is narrowband imaging is a new technique.
Sir.
You are studying those only patients who are having symptoms. Can this study would have been being in and we don't know what are the RSI scores actually, what are the RSI scores in disease, what are RSI scores in non-pathological conditions, normal persons. Could this study have been better implemented? Because it is OPD procedure, we are doing nothing invasive, doesn't take a lot of time, we have taken 30 patients. Could it have been better done?
So we can do all the patients with the voice disorder also, sir, in narrowband imaging. Voice, presenting with the voice disorder also, sir, and
Again, symptomatic patients.
symptomatic patients.
Would you like to know what are the scores in non-symptomatic patients? So that
Yes, sir. Yes, sir. So we could compare those control and comparative study would have been more better to find out the significance of these NBFs. Thank you, sir.
Good morning everyone. This is Dr. Manohar Reddy and my topic for today is A Stitch in Time Saves 9. Let's take some diversion and explore some of the cases which ENT surgeons will encounter, but not giving much attention and referring the patient to another specialty, that is trauma. Most of the ENT surgeons are in KGF mode. Whenever a facial trauma patient comes to ENT surgeon, they don't like it, they avoid it, and refer the patient to plastic or OMF surgeons. Here we can avoid it. But what if your own patient get dental avulsion or loosening while you are operating? For example, if there is a loosening or avulsion of tooth during intubation by your anesthetist, or dental avulsion happened while you are performing tonsillectomy or Laryngoscopy, So what we can do in these situations? Today I am here to introduce you all one of the easiest splinting method with which we can tackle all these situations. That is S6 wiring. So let's learn about this S6 wiring. All we have for fixing the avulsed tooth is 1 hour. Whenever you found a avulsed tooth, hold the tooth by crown, rinse it in water or saline, try to put the tooth back into the socket or keep it in saline or milk, whichever easily available media like saline, milk, green tea, and then fix it with S6 wiring. In our study, we aim to evaluate effectiveness of S6 wiring for avulsed tooth and dentoalveolar fractures. We included the patients who got iatrogenic dental avulsion, patient with avulsed tooth presented before 1 hour, patient with only dentoalveolar fractures without fracture extending to basal bones of maxilla and mandible. And we excluded the patient with avulsed tooth and presented after 1 hour, patient with dentoalveolar fractures with other facial fractures, and child with primary tooth avulsion. Every dental avulsion and dentoalveolar fracture patient were evaluated and treated with S6 wiring. We included 20 patients of dental avulsion or loosening and 7 patients of dentoalveolar fractures, then followed up for 2 months and results are analyzed. Our duration of study is 18 months. All we need for fixing these fractures or loosening of tooth is 26 gauge pre-stitched stainless steel wire, wire cutter and needle holder. Coming to the technique of wiring, a 30 cm wire is passed into interdental space from buccal to lingual and taken out from lingual to buccal, 1 or 2 teeth away from the fractured segment, and then wire is twisted with constant anterior pull, and then smaller wires are fixed in between the segment of fracture for further strengthening. Patient is advised not to bite directly on the replanted tooth for 3 to 4 weeks, soft diet and antiseptic mouthwash for 2 weeks, and to avoid contact sports. In post-op follow-up, patient is assessed for tooth movement, pain and inflammation. Periodontal ligaments and fibers will heal sufficiently after first week to remove the splint. Wiring is removed after 2 to 3 weeks. We can also use S6 wiring for stabilizing the mandibular fractures before definitive procedure, thereby reducing the pain and hematoma formation. S6 wiring along with IMF screws can be used in the treatment of symphyseal fractures with deep bite type of occlusion. We can also apply S6 wiring in dental subluxation, intrusion, extrusion and lateral subluxation. Advantages of this technique are it is safe to use, easy to use, time saving and cost effective, can avoid complications of arch bar fixation. Complications one can have is ankylosis, apical periodontitis and pulp necrosis. This is a case of dental loosening happened while intubating and fixed with S6 wiring. As we can see, one loop of wire is passed into interdental space and involving the loosened tooth and then fixed with smaller wires. And there is no dental movement after the fixation. This is a follow-up video of same patient after 4 weeks, and there is no complaints on the patient. This is a case of intrusion after trauma and fixed with S6 wiring on OPD basis after ruling out all the other fractures. Coming to the results, we operated 20 patients of dental avulsion and 17 patients had successful outcome with 2 cases of periodontitis and 1 case of pulp necrosis. And we operated 7 patients of dentoalveolar fractures with successful reduction achieved in 6 patients and 1 patient got converted to arch bar fixation. I would like to conclude with a note that we should come out of KGF mode because avulsed tooth need to be fixed immediately and no one will come to rescue your patient and you. These are my references. Thank you. Yes, sir. Yes.
One of the very bad. I wanted to know, when you took up the case of teeth, specifically, the problem here that I feel, more than a question, how do you know whether it is a disease diagnosis or not?
So we can test by palpation, like there is a
Then there are situations that you have talked about it, indication or other things. The tooth will get ours only and only when it is diseased, otherwise it is not.
okay.
Only or in old age, when abulus is there. If you talk about trauma, maxillofacial trauma, it's okay.
Yes, sir. We included patients coming to casualty also.
In
And
my operation theatre, a tooth will never get ours unless and until there is some amount of infection, some amount of mobility earlier than that. And if you fix, will there not be any problems? You are going into infected alveolus, recessed alveolus, trying to fix that tooth. There is an honest question, how do you take care of that? Forget about the traumatic patients. Where it is normal and you can fix it. I do understand.
so in our study, we had done 2 intra-op loosened tooth and 1 ulcer tooth, and there is no as such complications after that.
Whether there is a correlation with the age? Oh,
Yes, sir.
so okay, can you specify which one of the patients where you hold the children or
So one tonsillectomy patient, 10 years old child got ulcer tooth while we are opening a mouth with mouth gag, and second 2 intubation ka, those are old age patients.
old age?
Yes, sir.
Good morning everyone. Myself Dr. Amruta Tantak. The topic for my presentation is Sealing the Leaks, Our Journey. As we know, there is always a tug of war between a neurosurgeon and an ENT surgeon. A neurosurgeon would like to operate by an external approach, while we, the ENT surgeon, would like to operate endoscopically, thus reducing the chances of morbidity and mortality. As we know, the CSF rhinorrhea is an abnormal communication between the external environment and the CNS. It can be spontaneous and traumatic. If not treated on time, it can lead to complications like meningitis. Management should involve collaboration of various clinicians. Risk factors involves female, obesity, and middle age. Although CSF rhinorrhea has been traditionally treated with open surgical procedures, the introduction of the rigid endoscope for minimally invasive endonasal procedures has revolutionized treatment for many patients. The following are the causes of CSF rhinorrhea. It can be congenital or acquired. The aim and objective is to study various approaches for CSF leak repair. In our study, during the duration of 1 year from 2023 to 24, we had the total patients of 15, from which traumatic CSF rhinorrhea were 4 and spontaneous were 11. Initially, patient underwent proper history and examination. If active CSF leak was present, was sent for biochemical analysis. Defect localization was done by proper radiological imaging, and patients were treated conservatively for 2 to 3 weeks, following which patient underwent surgical intervention either by external approach or by endoscopic approach. As we know, neurosurgeons are also often associated with CSF leak repairs, but we ENT surgeons can also operate by external approaches to repair these leaks. Here we present a case which we operated by external approach. A 22-year-old male came with history of trauma with active CSF rhinorrhea. On imaging, there was a comminuted displaced fracture of both the inner and outer tibal of both the frontal sinus. And also there was a comminuted displaced fracture of bilateral cribriform plate and crista galli. The patient underwent CSF leak repair by external approach. A bicoronal incision was taken, flap was elevated, the fracture segments were removed. The defect was identified, as you can see, the defect, CSF leak defect. The entire mucosa was stripped off from the frontal sinus. As you can see, the entire mucosa is being stripped off from the frontal sinus. And the next, the defect was sealed in layers with fat, followed by Surgicel, and fibrin glue was used to seal the defect. Next, the fascia lata graft was harvested and was placed upon the defect. And again, there was again a layer of fibrin glue was used. The fracture segments were reposited and plating was done. Next, I would like to show by endoscopic approach, which is a forte of our ENT surgeons. We had a patient, 40-year-old male with history of meningitis. On MRI cysternography, a small defect was seen in the left cribriform plate with T2 hyperintense CSF fluid into the ethmoidal cyst. The defect was 1.1 mm. There was no significant parenchymal abnormalities seen. As you can see, there was a defect of 1.1 mm on MRI cysternography. Patient underwent endoscopic repair. The defect was identified. The CSF, as you can see, cauterization was done. Following which the defect was sealed with fascia lata graft and fibrin glue was used in the end. We also had a patient in whom we used Hadad flap. A superior incision was taken up to the mucocutaneous junction. Then an inferior incision was taken and both the incisions were joined and the flap was elevated. As you can see, the inferior incision is being taken. Both the superior and the inferior incisions are being joined. Then the flap is elevated. The benefit of the Hadad flap is that while operating, you can keep it in the nasopharynx so that it doesn't come in the way. The flap is being elevated. And then the defect was sealed with, the Hadad flap was rotated and the defect was sealed. We also use intrathecal injection of fluorescein dye in one case in which we had difficulty to identify the defect. You can see the yellow dye coming from the defect. Post-operatively, patients were advised complete bed rest and head and elevation. Prophylactic antibiotic was given. All measures to avoid straining was advised, like antitussives and laxatives were given. Nasal pack was removed after 5 days. Tablet Dimox was given for 6 to 18 weeks in tapering doses. Clearing of the nasal crusting was done on follow-up with diagnostic nasal endoscopy. Lumbar drain was used in some patients with high pressure leak. Result: the mean age of our patients was 6 plus minus 12 years with more preponderance to females. Post-traumatic patients, out of 4 post-traumatic patients, 3 patients showed complete recovery. External approach was used in 1 patient. Hadad flap was used in 1 patient with who had defect more than 1 centimeter. Fascia lata graft along with fat was also used in some cases. Fibrin glue was used in all cases. Intrathecal injection was used in one in which it was difficult to identify the leak. And post-op follow-up was done for 18 months. The overall success rate was 98%. To conclude, most of CSF leak close spontaneously within 7 to 10 days. Although most trauma-related CSF leaks solved without intervention, leak persisting for more than 7 days may require surgical intervention. CSF rhinorrhea can be managed both by external and endoscopic approach. Endoscopic intranasal management of CSF rhinorrhea is the preferred method, while high success rate and less morbidity than intracranial surgical repair. Though intracranial approaches should be reserved for some of the complicated CSF rhinorrhea from which who has extensive comminuted fractures of the anterior cranial base, the choice of approach depends on the site of leak, whether it is single or multiple leak, and the surgeon's choice. These are my approaches, references. Thank you.
How many patients were there in your study?
15, sir. Out of that, 4 were traumatic.
And what was your success rate?
Sir, 98%.
Did you have any failure?
Huh?
Did you have any failure?
Sir, there was one failure.
How much percentage?
Yeah. Yes. Sorry.
take-home message from this?
Yes, sir. Sir, usually ENT surgeons operate by endonasal approach, but in some cases it is difficult to approach some of the leaks, like if the leak is in frontal sinus or sphenoid sinus, or if there are multiple fracture defects. In such cases, we can go by external approach also. But again, the choice of approach should depend on the surgeon's choice, whether he is comfortable with the approach, the site of the defect.
Good morning everyone. The title of the study, the study title is The Factors Affecting Outcomes in Patients with Deep Neck Space Infections, a retrospective observational study. My name is Venkata Reddy. So introduction, the deep neck space infection is defined as infection in the facial planes and potential spaces of the neck. The stages of the infection includes cellulitis, abscess formation and necrotizing fasciitis. This is the slide showing the layers of the deep cervical fascia and neck spaces. The layers of the deep cervical fascia includes superficial layer and middle pretracheal layer and deep prevertebral layer. The space in the term deep neck space is a misnomer. It is not a true space. It is a potential space which develops after accumulation of the collection. So aims of the study is to determine the clinical and socio-demographic factors that influence the outcomes in patients diagnosed with deep neck space infections. The methodology, it is a retrospective observational study. So we retrospectively reviewed the case records of the patients in the last 3 years with the help of the HMI software. The study period was 3 years. The inclusion criteria, diagnosed cases of deep neck space infection of all age groups from the both genders were included. The exclusion criteria is post-traumatic infected wounds and infected head and neck tumors, and incomplete data for retrieval were excluded. The statistical analysis was analyzed by Stata version 14.0 software. So this is the slide showing results of the socio-demographic factors and clinical factors. So we included total 39 patients. The mean age was found to be 48.67% and male predominance was noted, and most of the patients belonging to the socio-economic status grade class 4 and 5, and 12 patients with diabetes mellitus, and 2 patients presented with Scheider. On examination, oropharyngeal bulge was noted in 6 patients and laryngeal edema was seen in the 5 patients. So this is the slide showing the results of the outcome variables. The management includes incision and drainage in majority of the patients in 24 patients, and followed by medical management in 9 patients, and incision and drainage with tracheostomy, ultrasound guided aspiration, and re-exploration was done in 2 patients. The need of tracheostomy was need for 4 patients for the compromised airway and anticipated airway compromise, and organism resistant greater than 1 antibiotic was seen in the 9 patients, and hospital stay greater than 7 days was seen in the 25 patients, and post-op ICU stay was needed for 5 patients. The etiology, the most common etiological factor in our study was found to be odontogenic infection, that is 51.28%, followed by peritonsillar infection and cervical lymph node infection, foreign body ingestion, and unknown source of infection is 20% cases. The organism isolated in our study most common was methicillin sensitive Staph aureus in 4 cases, followed by Staphylococcus aureus and Streptococcus pyogenes in 2 cases, and Mycobacterium tuberculosis in 2 cases, Streptococcus angiogenesis in 1 case, and Klebsiella in 1 case. So this is the slide showing one of the outcome variable, tracheostomy, with demographic and clinical factors. Out of the 39 patients, 4 patients underwent tracheostomy. Of them, 3 were male patients, and all belonging to the socioeconomic status class 4 and 5. Majority of the patients from rural background, and 1 patient was presented with Scheider, and 2 patients with oropharyngeal bulge, and 2 patients with laryngeal edema, and 1 patient with resistance to antibiotic greater than 1. So the patients who underwent tracheostomy was kept in observation in ICU. So this shows significant results in our study. So this is the slide showing one of the outcome variable, resistance greater than 1 antibiotic with demographic factors. Resistance was associated with younger age group with higher socioeconomic status. So discussion, in our study we observed a male predominance consistent with the previous large case series, that is Sang et al. The age ranged from 20 to 8 years with a mean age of 48.67 years. Recent studies also shown similar results. So diabetes mellitus was most frequently comorbidity encountered in our sample. A similar prevalence was also observed by Hang et al., so whose prevalence was around 30.33%. So odontogenic infections for 51.28% patients being the most common associated etiology in our study, as potential routes of spread exist from dental structures to nearby spaces such as submandibular, sublingual, parapharyngeal, buccal and masticator spaces. Peritonsillar abscesses in our case almost 12.82%, the second most reported cause. So it is also published by most of the others like Heng et al. Consistent with these studies. The main isolated pathogen in our population was methicillin sensitive Staphylococcus aureus. As other studies report, Streptococcus species were the most commonly isolated microorganisms, followed by Staphylococcus aureus. Streptococcus species were significantly associated with higher mortality rate. So this is the CECT image, axial image, head and neck, showing abscess in the submandibular and masticator space left side. This is the hypodense tract showing from molar tooth dental region. So this is the bone window of the image showing the hypodense lytic area in the mandibular molar tooth region. So CT scan with contrast enhancement is a part of our routine investigation. So as it permits not only to diagnose but also to delineate its anatomical extent, to prepare a surgical plan and to detect complications such as mediastinitis. Submandibular space is the most common site in our study involved. So this is the images of an interesting case of 33-year male patient with multiple neck space infection with no comorbidities and unknown source of infection. This is the CECT axial image showing the right side submandibular space collection. This is the coronal image showing the left-sided supraclavicular space collection and extending to the right side also. This is the sagittal image showing the air pocket collection in the sternocleidomastoid muscle. So this is the clinical images of 48-year-old male patient, female patient with Ludwig's angina showing the bilateral submental and submandibular swelling with mild floor of mouth bulge. Incision drainage was done and collection was drained, and this is the granulation tissue in the image. The hospital length was on an average 10 days lower than the reported other studies. We observed that the post-operative ICU stay was significantly higher in the tracheostomy cases. It is significant, and as per Joshi et al., diabetes mellitus and body mass index and admission to the ICU stay were significantly associated with hospital stay. We observed that post-operative ICU patients exhibited significantly higher blood sugar level at presentation, which is 283.85 versus 147, which is significant value, significant results, and HbA1c value was 8.96 versus 6.56, which is the significant in our study. Other markers such as creatinine, ESR also trended higher but not significant statistically. Conclusion. Deep location, due to deep location and complexity of these spaces make diagnosis and treatment difficult, hence been challenging for surgeons to manage. Early detection of the disease and aggressive approach of management is of utmost importance. Surgical management includes incision and drainage, culture-directed antibiotics, and tracheostomy when there is impending or established airway obstruction. The take-home message is understanding of the anatomy of the cervical facial planes is key to diagnosis and management. Cross-sectional imaging where possible will provide extremely useful information to aid treatment decision making. Assess the teeth and arrange the orthopantogram for submandibular space infection is important, and assessment and management of the airway is required alongside the treatment of underlying infection. These are my references. Thank you.
What is the single most important factor that affects the outcome of the patient in taking this patient?
Sir, comorbidities may in our study we see.
I'm asking a single most important factor that affects the outcome of patient with head neck space.
Some most age was one of the factor, and underlying comorbid condition is the.
You are not included that in your presentation. That's why I'm asking. The site of abscess, the space involved, and you will not talk about it. But
Yes,
you cannot understand after seeing this paper which spaces were involved in these patients.
in submandibular space is one slide I explained most common.
All patients were not observed, cannot be observed in this space.
Yes.
How many retropharyngeal, how many parapharyngeal, how many mediastinal?
Yes.
And do you think necrotizing fasciitis as an extension of an abscess? Is it a stage of abscess or is it a separate disease?
Sir, it is a separate disease.
Do you have a patient of necrotizing fasciitis in your presentation?
No, sir. No, sir.
Good morning, everyone. Otological surgeries have been done since many years, and we've been using drill machines as well to operate and to do mastoidectomy. But have we ever wondered what happens to the other ear? So today Dr. Anirudh will be presenting my case presentation on this topic only to find out the effect of conductive hearing loss in the contralateral ear. So drilling during otological surgery produces significant noise and vibration which can be transmitted to contralateral ear. The outer hair cells in the cochlea are the first one to be impacted. The mechanical energy generated by the OHCs is called the otoacoustic emissions. This study was thus undertaken to shed light on the degree and duration of contralateral ear hearing affection and its correlation with the total drilling duration, type of burr, that is cutting or diamond, size of burr, irrigation during drilling, and rotation per minute of drill. Objectives of the study were to compare the drilling effect of drilling on the contralateral normal ear bone conduction on following parameters: the type of burr, size of burr, duration of drilling in minute, and rotation per minute, and irrigation used. These were then evaluated on the following parameters: pure tone odometry, transient evoked otoacoustic emission, and distortion product otoacoustic emission. Methodology: the study design was a prospective observational study. The study duration was 2 years. The study setting was a tertiary care teaching hospital, and the sample size was of 25. Selection of patients: the inclusion criteria had subjects diagnosed with unilateral ear pathology undergoing otological surgery where drilling is used, subjects with normal contralateral ear, and patients who are willing to undergo post-operative sequential PTA and OAE. Exclusion criteria included patients suffering with bilateral ear disease, patients with sensory neural hearing loss, patients with a previously operated contralateral ear, those who are not willing to undergo post-sequential PTA and OAE, and those who are not cooperative for the procedure. Dual channel diagnostic audiometer along with their headset for air conduction and bone conduction were used. Detailed history and ENT examination was carried out. The bone conduction of contralateral ear were recorded in decibels, and the preoperative bone conduction threshold was taken as a reference normal value. For otoacoustic emissions, we used interacoustic auto-read apparatus. Thus, the distortion product otoacoustic emission was divided into low frequency, that is 2000 Hz, and high frequency 3000, 4000, and 5000 Hz. Similarly, transient evoked otoacoustic emissions were divided into low frequency and high frequency respectively. NSK drill machine inbuilt irrigation was used. Total drilling duration was divided into 3 groups, namely less than 20 minutes, 20 to 40 minutes, and more than 40 minutes. The individual drilling time duration with cutting and diamond burr were also documented. Post-operatively, PTA, transient evoked otoacoustic emission, and distortion product otoacoustic emission was recorded on day 1, 2, 3, 7, and 30. So the results showed out of the 25 patients, the average age was of 29.64 plus minus 8.703 years. Female to male ratio being 1.7:1. Mean duration of ear discharge in the patients was 5.2 years. Intraoperatively, 80% of the bone drilled was sclerosed. Mean total duration was of drilling machine was 28.93 minutes. Maximum 60% patients underwent drilling for the 20 to 40 minutes. Irrigation were used in all the patients with an average RPM of 80,000. So on PTA, there was no evidence of post-operative hearing loss. On the discussing the effect of the duration of drilling on otoacoustic emissions, the distortion product otoacoustic emission showed significant positive correlation with total drilling duration for 3000 Hz. On increasing the duration of drilling, median days taken to return to pre-operative value of distortion product otoacoustic emission increased. Thus, this was shown to increase more in lower frequency. The transient evoked autoacoustic emission showed non-significant positive correlation with total drill duration. Depending on the type of burr, the distortion product or autoacoustic emission showed positive correlation with cutting burr, which was statistically significant for 2000, 4000 and 5000 Hz and non-significant for the 3000 Hz. The transient evoked octoacoustic emission showed positive correlation for cutting and diamond burr as well. This was statistically significant for cutting burr at 4000 Hz. The effect on the size of cutting burr and the effect of size of the diamond burr were also discussed. On increasing the size of the cutting burr, the time taken for hearing to return to normal increase for higher frequency, with great range for frequency being affected by 6 millimeter cutting burr. The distortion product shows positive correlation with 1 to 3 millimeter cutting burr. Statistically significant correlation was seen between 1 millimeter cutting burr and distortion product autoacoustic emission at 2000 Hz, 4000 Hz and 5000 Hz. Positive correlation of high frequency transient evoked autoacoustic emission with small diamond burr and low frequency transient evoked autoacoustic emission with large diamond burr was seen in this study. In contrast, the distortion product autoacoustic emission only showed a positive correlation with a 2 millimeter diamond burr. On concluding, this study showed maximum impact on post-operative day 1 on transient evoked as well as distortion product autoacoustic emission. Maximum 72% subjects hearing returned back by day 7 and all patients hearing reverted back to normal by 30 days. Thus, transient effect on hearing of the contralateral bone conduction post-operatively was noted on autoacoustic emission, while on PTA there was no evidence of post-operative hearing loss. These are my references. Thank you.
Good study. One question, you have compared with all burr sizes, burr types.
Yes.
Do you think that reducing the speed of the drill will make a difference? Because all the drills, what you are talking about is 80,000
yes.
RPM. So if you use a 40,000 RPM, will it make a difference? You want a question?
Yes, sir.
Yes. Because the speed has got relation with your drilling rate.
Yes.
You have compared the burr size, burr types.
Yeah.
Why you have not compared the speed? Because the speed makes a difference.
Yes, sir.
So, do you think? Let's have a discussion.
Yes, so I think the speed of the drill used can also affect the hearing of the contralateral ear as well. If we are reducing this speed of the drill time, it can also lead to, a decrease in the recovery period as well. Because if 80,000 shows the patient's hearing recovery is by day 7, then 40,000 might show the hearing recovery before that as well.
So it can be advisable to use a
Yes.
RPM?
Yes.
But our
good.
all drills are to
80,000.
RPM not because that will be important.
But then what's the reason behind this hearing loss?
Sir,
Why we are having a hearing loss?
So actually the vibrations which is caused by the drill can get transmitted to the contralateral ear as well, which we are not operating.
So why it's coming back? I don't understand.
You got the question? What you
Yes, sir. Yes, sir.
So why there is a transient loss and why it is coming back? If it is a sensory neural, it will not come back. And if it is coming back means, and it is coming automatically, you are not doing
Yes, sir.
Conductive.
Yeah.
Yes, sir.
It can't be sensitive. So what? I mean, what some another type of hearing loss?
No, sir. Actually, on PTA,
Your study is very good.
Yes.
We have thought out of the box.
Yes.
Very good. But the
the reason is not to be understood. I'm trying to, nothing for the...
You need the evolution of sensitivity. Something called a short-term threshold shifts, mid-term threshold shifts, and then long-term. Sensitive neural hearing loss doesn't, in all cases, develop de novo at one point. There are sensitive neural hearing loss which develop and get short-term threshold shifts, which would come back. That is what is happening.
What was the...
Sir talked about frequency, but why not talk about the disease for which we are doing? Because site at which we are doing will also be important. Will it not be?
Yes, it will.
Over the larynx,
Yes, sir.
cortex memory, ear eye.
Sir, it will.
I'm going to add that speed comparison.
Okay.
Otherwise, it's very knowledgeable. What was the basis of this study? What was the reference? Can you give me the one important reference from where you have taken this idea to study?
Sir,
just for the discussion, because it's very good study.
Sir, actually, one of our patients, like most of the patients.
No, reference study. From where you have taken? From the laryngoscope. What is the reference? Can you show me the reference?
Yes.
Because I want to know the reference from on which it is based.
Sir, in this.
There are better results for the...
Sir,
Good morning everyone. Today I am presenting my case titled as Multifariationess of Histopathological Results in Thyroidectomy Specimens, a case study. I would like to say some points in introduction. We all know that thyroid swellings are one of the most common swelling in the neck. They pose major problem in areas of India like Himalayas, considering in high endemicity of iodine deficiency disorders. Thyroid gland is affected in many conditions like in functional immunomediated to neoplastic lesions. Here is a picture of anatomical locations and blood supply of the thyroid gland. Then there is next picture showing the histopathological picture of the thyroid gland showing the principal cells, peripheral cells, including colloid materials. And later there are types of the thyroid disorders like simple goiter showing the diffuse hyperplastic multinodular, next toxic which also shows diffuse and multinodular types, and neoplastic which are benign and malignant. Later here is elaboration of the thyroid neoplasm types benign and malignant. Aim of my study is to describe a different pattern of lesions in thyroidectomy specimens in colloid goiter. And objective is to study various histopathological variations of thyroidectomy specimen in FNSC reported colloid goiter. This study was conducted as a retrospective and observational study in 7 cases in duration of 6 months, which consists of patient presenting to the ENT department with anterior neck swelling, with thorough history and physical examination of patients was conducted, and once FNSC category for patients was established according to the Bethesda system, treatment was carried out in the form of surgery. After surgery, excised specimen were thoroughly examined and histopathologically an outcome is studied. Here are some of the pictures of thyroidectomy specimens which are diagnosed on basis of the histopathological results. First is colloid goiter, next is thyroglossal duct cyst, third is a papillary carcinoma, and fourth is a multinodular goiter. Results. So total 7 thyroidectomy specimens were studied in durations of 6 months, which were 6 were females and 1 was male patient. And FNSC and histopathological non-correlation studies was found in the 42.86%. First was follicular adenoma as benign neoplasm. Second was papillary thyroid carcinoma classic type, and third was a non-invasive follicular tumor with papillary-like nuclear features. All these thyroidectomy done were first diagnosed as colloid goiter on FNSC. So my conclusion was FNSC in thyroid cases is of utmost important in making preoperative diagnosis. FNSC is found to be highly sensitive and specific for diagnosing thyroid lesions. However, final histopathological examination is considered as gold standard. Here are some of my references. Thank you.
What are the reasons for this variation in histopathology and FNSC results in thyroid?
Sir, we can consider different types of reasons. It can be default technique for collecting FNSC specimen, and later on it can be subjective error also to examine specimen under the
keep apart the subject area. We will assume that they will not happen because we reference will be seen as methods. Can we decrease this various difference between FNS report and are there any ways that you can propose by which we will have better idea of what pathology is there by FNS?
Yes, sir. We can decrease it by collecting more than 2 sites for collection the FNSC sample, so that multiple areas can be studied.
Can you do something different so that we will have a proper US guidance? Do it under US guidance so that you hit the most solid part, you hit the most proper part from where you want the specimen.
Yes.
So that your histopathology will be more like.
You didn't mention about some system they use for FNS. You are aware of some system they use for FNS?
Yes, sir. I have mentioned Bethesda system.
All the papers have been concluded for today in JALGAON MENTCON PG Award papers. I would love to request the judge, Dr. Prashant Hippalekar sir, to please come forward. I would love to request the chairperson, Dr. Khandekar sir, Mubarak Khan sir, and Rajesh Yadav sir to please come forward. Mubarak Khan sir, please hand over the certificate to our judge, Dr. Hippalekar sir. I would request Dr. Bagdi sir to please come forward. Bagdi sir will hand over the certificate to Dr. Khandekar sir. I would request Dr. Bagdi sir to please hand over certificate to Dr. Mubarak Khan sir. And Dr. Rajesh Yadav sir. Thank you, sir. Hippalekar sir, please come forward. You have to distribute the certificate to the participants. Sir. नहीं रिजल्ट आता नहीं.
Organizing letter. It will be declared in last session.
ठीक सर.
ॲव्हरेज काढायला लागेल तुला. रिझल्ट तयार कर.
चालेल.
आणि ह्याच्याकडे देऊन टाक.
शहा सरांकडे देतो मी.
सर्टिफिकेट डिस्ट्रीब्यूट करून.
डॉक्टर अपराजिता, डॉक्टर मनीषा KS, डॉक्टर शानमुगदेवी, डॉक्टर ज्योति खडका, डॉक्टर खांडे सर प्लीज, Dr. Manohar K. Reddy. Dr. Amruta. Dr. Mula Venkata. Dr. Anirudh Sinha. Dr. Swarali Varkoti.
Yadav sir.
Rajesh Yadav sir to hand over the certificates to Dr. Swarali Varkoti. Thank you everybody. We have concluded this session. We'll join us at 11:30 a.m. in this Vayu Hall for JALGAON MENTCON Consultant Award Papers.